Yes, hi. So I'm here to present virtual healthcare inequity in Ontario on behalf of our larger HSPN team. So for our project specifically, we were tasked with answering the question of what has been the impact of expanding virtual care for diverse populations. So in order to answer that question, we reached out to ICS to get data on all of the physician appointments that happened in Ontario between April 1st, 2018 to March 31st, 2023. To be eligible, a person would have to be an OHIP holder, except of those with an valid birth date or gender or age over 105 years. And for analysis today, we'll present some of the descriptive statistics of other counts of how many appointments happen per month or per year, as well as rates of use, so that we can sort of compare them from group to group. So this is the list of all of the equity stratifiers and variables that we took a look at. So physician visits could be administered in person or virtually for mental or physical concerns, as well as for primary or specialty care. Patients were analyzed based on their age, sex, and CHI grouper that allowed us to see the number of physical or mental health conditions that each individual has, as well as immigration status. And for neighborhood variables, we specifically will discuss material deprivation. To bring us into this topic, here is a slide of total monthly in-person and virtual visits in Ontario from April 2018 to March 2023. As you can see, in April 2020, there's a huge dip and an appearance of this green bar, which is the virtual care. As you can see, we have on average about 19 million appointments per month, physician visits in Ontario per month. That number had dipped for the first couple of months of COVID, by about 46% or so, at which point we had the highest share of appointments administered virtually, up to 35%. And ever since then, the share as well as the actual number of visits have been steadily sort of declining from month to month. These are some of the trends of how we use virtual care more. So it's mostly used for primary care, as before and after the pandemic, used for both mental and physical concerns, mostly for physical concerns. However, we do see an uprising of mental health appointments every month, administered virtually. So who are the patients of virtual care? They are Ontarians. Not the majority, but a large piece, a large slice of appointments are administered for patients of the age of 65 and above, both virtually and in person. Women are also more frequent users of healthcare and use virtual care more in conjunction with in-person care. Patients with 5 or more health conditions are responsible for more appointments in person and virtual. And as I had mentioned before, as the time goes on, more patients return to in-person care. So our next slide is going to help us visualize the breakdown of total annual healthcare use by age. So these are all of Ontarians registered with OHIP and their use of healthcare. Basically, whether they had in-person visits only in one fiscal year, or had both virtual and in-person visits, or just had virtual visits only in one particular fiscal year, you can see. As you can see, the older population doesn't amount to as many people. However, they do have a higher rate of use, so they do require more appointments per year to sustain their health. The next slide will show us a bit more about sex comparison, male to female. As you can see, we do have more women living in Ontario, and they do use care more. They use care more virtually, as well as in conjunction. But as you can see, this little green sliver is diminishing as we go on from year to year, moving away from the pandemic. And our next slide will give us a bit more information about the CHI pop grouper. As you can see, patients who have 5 or more conditions are the heaviest users of healthcare, understandably. And now that we look at equity stratifiers by residence, which is our next slide, we learned that overall individuals in least deprived neighborhoods have a slightly larger population and contribute to more in total visits, both virtual and in person, by the virtue of them just being more people in quintile 1, which is least deprived. But if we look at rates of visits per person per year, then we do find that individuals in neighborhoods with higher deprivation have more in-person visits. Post-pandemic, this is slightly weaker relationship. Now, pre-pandemic individuals in higher deprived neighborhoods had slightly higher virtual care visits per person per year. Post-pandemic, virtual care is now the same across material deprivation groups. And our next slide is going to exemplify the first point that we were making. As you can see, Q1, which is the least deprived quantile of Ontario populations, is just right there on top, but we do have more people within that category. Now, if we look at the following slide, which will show us specific rates of healthcare used by material stratified by material deprivation, then you will see as we move across from Q1 with least deprived to Q5 with most deprived, you can clearly see this sort of a slope up and the need of more appointments. And these are a number of appointments per person per year. Just to clarify exactly what we're looking at here, as you can see, there was some pre-pandemic, just this slight green sliver on the very right at the Q5 before the pandemic. Our Q5 population who was most deprived was using virtual care more than other populations. However, after the pandemic, virtual care had become equally accessible to all material deprivation sort of neighborhoods of all kinds. And the final couple of takeaways. So the amount of virtual care increased overnight, of course, as we saw COVID-19 pandemic and with all of the restrictions of seeing everybody face to face. Ever since then, virtual care has been declining slowly. Most individuals with virtual care also seek care in person, and we see that trend highlighted even more now that we move away from the pandemic. Individuals with higher deprivation have more in-person visits per person per year. Post-pandemic, this is a slightly weaker relationship. And overall, we find that it appears post-pandemic that people in higher deprivation neighborhoods may have lower access to care as compared to those in areas with lower deprivation.